Yeah. Myself, Dr. Dinesh Padole from India. I'll be presenting my case, fishing in coronaries, loss of equipment. To start with, I'd like to thank GIS to invite me and let me present these cases. So going ahead. So my first case is a 50-year-old man with hypertension, dyslipidemia, presented to ER with worsening chest pain after his regular workouts. ECG showed inferior ST elevation. So as a regular, STEMI team was activated. The catch showed TVD, LAD was diffusely diseased with maximum stenosis of 80%, LCX was okay, OM proximal 90%, but the culprit was RCA. The PLV was completely cut off from the proximal segment, as we can see. So went ahead with a regular primary angioplasty with stent to PLV, radial approach, Schwann blue wire, easily crossed into the PLV, lesion pre-dilated with 2.5 into 15 mm non-compliant balloon. Again, regular stuff. Yeah. So, yeah. This is not. Yeah. So, stent position and stented. Everything looks well. Okay. So going ahead with post-dilatation, took a 2.75 into 12 mm balloon, as you can see, expanded well, started from the distal part of the stent to the proximal part of the stent. But when everything looked fine, suddenly just tried to normal, I told the nurse to deflate it and just started to remove, but suddenly I thought something is missing in my hands. So the balloon was partially inflated, and my bad luck, the wire also came out. But luckily, the flow was there, so balloon is partially inflated. So RCA was rewired, and I put in 3 to 4 wires. And it was swirled for 30 to 40 seconds. Sir, it was the mid of the shaft, not the top end of the shaft. So trapping was an option, but the risk for the trapping was if it is not in the catheter and if we pull it out, then the wire and everything goes out. So that was an issue with that. And so eventually, 3 wires inside, swirling motions, continued swirling motions, and eventually pulled back with this final result. Going to the second case, so this was an LAD, the mid-distal part, as we can see, started pre-dilating with 2.5 into 12 mm NC balloon. The lesion didn't yield well, so went up to high pressures, so looked well. So decided to stent it from the proximal part to the distal part with a long stent. The stent was positioned and it was stented again. Now started with the post-dilatation, took a 3 into 15 mm NC balloon for the mid and the proximal part of the stent. Everything went well. For the distal part, took a smaller balloon, 2.75 into 8 mm NC balloon, and trying to push it, it didn't go in well, and then just realized that it is broken again. But this was the time the wire was inside. So again, similar technique, swirling wire technique was used. 3 more wires, slowly and steadily introduced. 2 wires went in. Third one couldn't go in, but still it was kept above. Again swirled, continued swirling, and eventually inside the catheter, and we pulled it. But while pulling it, here, as you can see, here, the balloon is now inside, but the wires are out, so we had to eventually pull out the catheter and ascend entire assembly. So again, re-engaged, rewired, and post-dilated with a balloon again. obtained a decent result, and finished the procedure over there. The last case, third one, this was a regular angio. As we can see, the left system, the OM is cut off from the proximal segment. LAD has intermediate lesions, not many significant. The RCA couldn't be engaged with TIG, JR. It looks like a high up origin, couldn't locate it. Eventually took a AL, trying to find it, not getting it, and broke the catheter. And this is a new catheter, but it was on the shelf for an year. That was the issue. It's a new catheter. So this catheter is hanging now, and I don't have a snare. So trying to catch with a handmade snare. So we made a snare. It took 5 minutes to make a snare. So trying to catch it from the proximal end and the distal end, not successful. So the technician called the interventional radiologist, where is their kit for the snare? Because they had the snare, we didn't. So till that time, what to do? So we changed to an 8 French system, and someone suggested in the lab to try to take a JR and try to wire and balloon and take it out, which is a nonsensical idea as such. So still was trying, and as you can see, now the catheter has come from the ascending rudder to the arch. Still trying, and while I was doing this, I can literally feel the catheter hitting it, and I'm having a false hope that I may cross it. So I'm still trying. So eventually got a peripheral snare, went inside, tried for a few minutes, and eventually caught it. So it came inside. So eventually it came inside the 8 French sheath easily. So these things happen, so we have to be calm. Because the patients are usually stable, as Dr. Firdaus said, the operator is unstable, and the patient is usually stable. And there are multiple techniques, as we have already discussed through the day, multiple wire techniques, narrowing, passing another balloon distillery, trying to pull it out. If you are lucky, and if the shaft of the balloon is in the catheter, then balloon trapping can be tried. And learning a handmade snare is easy. One can learn it easily. And the last option is calling a surgeon and surgical removal. Thank you.
Great, thank you very much.